Okay, thank you for inviting me for this talk. Thank you to Poonam and to the Nebraska WIC. This is a fantastic occasion, and I'm so happy to be talking about hypertensive disorders in pregnancy and postpartum, and what is their clinical implication for cardiovascular health. And it's great that there is a specific topic on cardiobstetrics at this conference. So thank you for having me. I have no disclosures. I really would divide this talk very quickly, and I know I don't have much time. But really to talk about hypertensive disorders of pregnancy as an overall problem during pregnancy and postpartum timeframe, as well as from long-term cardiovascular implications. And then quickly go over the ACOG and AHA management guidelines and some pertinent important things that a cardiac doctor should know about this problem. And I'll keep it case-based, so it's fairly easy to follow. I'm going to present this case. This is a lady that I recently saw in my postpartum clinic, postpartum cardiovascular clinic, and she's 26 years old. And came for a pre-pregnancy counseling in that clinic. She was contemplating her second pregnancy. The important problem that she had is existing chronic hypertension and was on nifedipine XL daily for it with relatively good blood pressure control. In her last pregnancy, she had a significant complication with preeclampsia with severe features, and that's really defined as a blood pressure greater than 160 over 100. 10 millimeters of mercury and associated with some form of end organ damage, and we'll talk a little bit about it. And that necessitated preterm delivery, and early preterm delivery at about 32 weeks. And she was very concerned about her second pregnancy and wanted to know what were her long-term cardiovascular risks, as well as her risk of developing preeclampsia subsequently. So how would you counsel her? So, before we get into that, I'd like to introduce the important context of adverse pregnancy outcomes and how we're thinking about cardiovascular disease in pregnancy. And while we do recognize that adult congenital heart disease, or women who've had adult congenital heart disease such as Fontane's or repaired tetralogy of Lowe, and even the WHO one or two categories, or valvular dysfunction, cardiomyopathies, aortic problems, Marfan's or Danylor's, chronic coronary artery disease or pulmonary hypertension constitute a significant portion of the chunk of the patients that we see in cardiovascular disease in pregnancy or cardiobstetrics. The field has grown to involve adverse pregnancy outcomes, such as hypertensive disorders of pregnancy, gestational diabetes, preterm delivery, early and late preterm, and small for gestational age as important risk enhancers or risk factors that should be considered while counseling these women. And this is really the new paradigm of prevention from a cardiovascular perspective in these women. While we do know that hypertensive disorders of pregnancies are increasing, the pre-existing risk factors, such as advanced maternal age, or hypertension, obesity, and dyslipidemia, as well as insulin resistance of the maternal population, has also increased over time, somewhat, deepening our understanding of why these women may present that way. So, what is the scope of hypertensive disorders of pregnancy? Very common problem. In some countries higher than obviously 8%. In the United States, probably around 5 to 6% pregnancies are affected with hypertensive disorders of pregnancy, leading causes of maternal and perinatal mortality worldwide. In the United States, 16% of maternal deaths or pregnancy-related deaths in the postpartum phase are from hypertensive disorders of pregnancy. In 2002, the estimated cost of preeclampsia as a disorder and the first 12 months of delivery was about $2 billion. So it was a huge problem for the US. And this is from the recent Age Consensus Guidelines, chaired by Lakshmi and Carol Warnes, that looked at what are the 4 different types of hypertensive disorders of pregnancy, while preeclampsia and eclampsia is the most severest concern, which is new onset hypertension of blood pressure greater than 140 over 90 millimeters of mercury, and this is the ACOG definition, after 20 weeks of gestation and association with significant proteinuria or end organ dysfunction is the major type. There are other not so benign types as well, such as gestational hypertension, chronic hypertension, and chronic hypertension with superimposed preeclampsia. And there's another more malignant form of preeclampsia called the HELP syndrome, which we'll talk about later. So the criteria for preeclampsia, like I talked about, obviously, blood pressure cutoff, and then any of these following, which is proteinuria greater than 0.3 grams in 24 hours, a low platelet count, a high creatinine, liver dysfunction, pulmonary edema, headaches, and visual symptoms. So what do we know about pathogenesis of preeclampsia? We think that the problem is with the placenta, and this is sort of very widely hypothesized and considered as the main problem, which is incomplete placentation, incomplete placental penetration, abnormal placentation and dysfunction. What we do know is that the preeclamptic spiral arteries are not as vasodilated and deep and wide as the normal placental spiral artery. So it leads to this incomplete placentation where the spiral arteries are vasoconstricted and are shallow and don't penetrate deep into the myometrium as compared to the normal placenta. And there are many hypothesizing reasons for it, such as innate immunity, some problem with the immunological factors, genetic factors, underlying cardiovascular risk factors, inflammation, autoimmune problems, so on and so forth. But this sort of impaired placentation and vasculogenesis happens in the first stage of preeclampsia or early pregnancy, and then into the later part of pregnancy or 20 weeks onwards, when the fetus really requires more nutrition and grows overall in size, is when we start seeing the clinical manifestations of preeclampsia, which are all displayed up here. But really, the theory has been that there are multiple, factors that are associated with it, and one factor that has been used as a screening test in some countries to reliably predict preeclampsia is the SFELT placental growth factor ratio, which is also my area of research. If you look at the SFELT, which is really, an androgenic biomarker, it really competes with placental growth factor to the VEGF receptor, which is vascular endothelial growth factor, and prevents endothelial development and causes endothelial dysfunction. And that we think is the basis probably of preeclampsia. And there are more studies that we can talk about it later in the Q&A section about how and when to look at this. But that's really thought to be an endothelial problem that arises from incomplete placentation. We do know that there's maladaptive changes in preeclampsia, while there are normal physiological changes in pregnancy. Those are impaired in preeclampsia, where the mean arterial pressure is high, the SVR is high, the cardiac output is lower, GFR is lower, there's increased insulin resistance and subclinical activation of the coagulation system, which leads to the most devastating form of preeclampsia, the malignant form, which is the HELLP syndrome, which can lead to maternal death. We do know that preeclampsia with severe features, as this patient had, would require to fit these definitions, which is a systolic blood pressure of greater than 160 over 110, 2 separate occasions, 4 hours apart, and visual changes, headaches, seizures would make it HELLP syndrome. But so on and so forth. So what can we do, or what do we recommend? The ACOG will recommend use of aspirin about 12 weeks onwards in patients with preeclampsia, with type 1 or type 2 diabetes, autoimmune disease, chronic hypertension, multifetal gestation, renal disease, and so on and so forth. There are certain considerations. For example, if you have an obese lady with a prior history of preeclampsia or a family history of preeclampsia, or age greater than 35, some OBs and MFMs may consider putting them on aspirin as well. So the second question is, would you change her medication? We know that she was on nifedipine. Would you change it to labetalol or alpha-methyldopa? The answer is not necessarily. While the ACOG recommends alpha-methyldopa or labetalol as a first-line agent, or hydralazine can be used in order to get the blood pressure down, there's a recent study came out in the Lancet that looked at the efficacy of nifedipine, labetalol, and alpha-methyldopa in controlling blood pressures in patients with hypertensive disorders of pregnancy during pregnancy. This has about 900 patients, 300 in each group. And what they found was the nifedipine resulted in a greater frequency of primary outcome of maintaining normal blood pressure as compared to labetalol, and definitely better than alpha-methyldopa. All 3 drugs actually were associated with treating severe hypertension, so maybe a considerable option in low resource settings as well. So the other question we get asked a lot in these patients who have chronic hypertension or considering pregnancy or who are on beta blockers, is it safe to continue beta blockers? And this is a more stylistic thing that requires, patient centered and patient interaction and sort of shared decision making, and many women choose not to be on beta blockers. But there is data now that maternal beta blockers are not really associated with congenital malformations and are not associated with cardiac malformations. What they are associated with, and as seen in these pooled analyses from Nordic database, the US database, is that the beta blockers are associated with cleft lip and palate. But in terms of cardiac manifestations or congenital manifestations, they are generally not associated with them and can be considered a safe option, especially labetalol, which has both alpha and beta antagonistic activity. So again, this is a nice flow chart from the guidelines that looks at type of antihypertensive therapy with women with chronic hypertension who are desiring pregnancy. And again, beta blockers, alpha-adrenergic agonists, calcium channel blockers, and vasodilators can be used. And one thing to note though is atenolol is associated, and even propranolol, but mostly atenolol is associated with intrauterine growth restriction, and hence is not a preferred beta blocker. We choose to use either labetalol, metoprolol, or carvedilol in patients who have cardiomyopathy. And you know, intravenous hydralazine can be used as a first-line agent in patients with severe hypertension with severe features, but you've got to keep in mind the syndrome of reflex tachycardia and be careful to not drop the blood pressure down too quickly. Management of severe hypertension in pregnancy. This is a little outside the league of what cardiologists do because we don't really manage these folks. However, we do get asked sometimes if we would use these agents, and I think generally the goal is to control blood pressure, make sure that you give them the patients IV magnesium to prevent seizures, and you know, can get them controlled as quickly as possible. And sometimes it may lead to iatrogenic preterm delivery. So why is this lady coming to me? Because she wants to know a little bit about her future cardiovascular risk associations. This is a great study that looked at greater than 10 years and less than 10 years risk association of preeclampsia with cardiovascular disease. And you can see that while greater than 10 years, preeclampsia is definitely associated with coronary disease, heart failure, and stroke, that risk is actually higher within 10 years of having the index preeclampsia. And that's where I think the importance of educating health promotion, risk factor assessment, management, close follow-up is important, because this is where you can identify these unhealthy risk factors and sort of change the trajectory of the patient. And it's really critical that these women follow up with cardiologists or with primary care doctors. These women typically will not be interfacing with us. They're younger, they don't really have a whole lot of risk factors, and generally don't see a cardiologist. And I think that's important and perhaps something that we should talk about and change within our institutions. Hypertensive disorders of pregnancy are not only associated with cardiovascular disease, coronary artery disease, but also premature aging. This was an interesting study that came out of Mass General and Brigham. They looked at the UK Biobank and saw that in addition to what we know, there is also vascular aging and valvular dysfunction that is sort of premature in these women. So important to note that and educate that. Thank you.